Let's go ahead and get started on that last one. And I apologize that the last talk is oncology. I mean, that's like not right, you know. Um, of all, that one you need most, that's gonna just that's just brutal. But we'll try to make it as painless as possible. I don't know how we do that, but we'll try. So I focused a lot. I thought a lot about this, and I thought, what type of oncology questions can you ask that don't change every 15 minutes and that stand the test of time? Because every time that a board question is written, it costs the national board a lot of money. They bring in people for these meetings, they have to go over them again, and it's estimated each question costs probably $1,000 to $1,500 to develop. So you want questions that can endure. So my thought is that really focusing on things like paraneoplastic syndromes, things that have not changed over time, and big sort of changes in how we do things that are sticking over time, as opposed to the latest and greatest biologic that's out there. So that's what I've tried to do. Now, the other thing is I am not an oncologist, okay? So, I'm a general internist. So, some of the really, you know, second and third level oncology stuff, I don't think you're going to be tested on it. And if you have questions, I'm probably going to say I have no idea. So let's go ahead and get started here. A 50-year-old man presents with a bulge in his left scrotal area. He has noticed it for the past 3 days. So this is a new development for him. Exam reveals a left varicocele. Hemoglobin 15, hematocrit 45, UA 10 to 30 red cells. What is the most likely diagnosis? Renal cell cancer, renal vein thrombosis, prostate cancer, or inguinal hernia? So I think A and B are both right. I mean, the thing I'm trying to get at here is sudden onset of a varicocele and the association with renal cell cancer, but it also, part of that is most of it is because of tumor propagation up, and then it increases pressure. So that is effectively like a renal vein thrombosis. And then some of these people do get renal vein thrombosis. So I think A and B are both right. Um, so this is a rare paraneoplastic or a neoplastic syndrome with renal cell cancer, which is more of a structural thing, sudden onset of the varicocele. But renal cell cancer has been called the internist tumor because it's got a bunch of weird paraneoplastic syndromes. 20% of these people may have fever. They may develop new hypertension, erythrocytosis in 3% of these people, that they actually can get too much erythropoietin production, because of the effect on the kidney. But the interesting thing is most people with renal cell cancer present with anemia as opposed to erythrocytosis. And the more interesting one is non-metastatic hepatic dysfunction. That is transaminases that go up, and you first think that they must have a MET, but they have a clean liver. And then when you remove the tumor, the hepatic dysfunction goes away. The transaminases get better. So it's kind of a very, very interesting tumor. A 67-year-old man has sudden appearance of 30 lesions on his back and chest. These are new for him. He's never had lesions like this before. So here is what it looks like. He's got a bunch of these all over his back and chest. Just came up in the last couple of months. What diagnosis is of greatest concern? Cutaneous lymphoma, HIV, gastric cancer, testicular cancer, or multiple myeloma? So the right answer here is gastric cancer. These are sort of the sudden onset of seborrheic keratoses And this has been described as a sign of Laissez-Trillat. Now, it's interesting because over the years, this has been something that has shown up on ABIM boards, but there's been some criticism of this sign, like, is this a real sign? Is this something that's really true? So I just throw it out because it's been on boards before. I want you to have seen it and thought about it and know that the association of this sign, if it really does exist, has been generally non-Hodgkin's lymphoma and GI adenocarcinomas. Gastric cancer has been probably the most common GI adenocarcinoma associated with this. A 48-year-old woman with metastatic breast cancer reports she has been unable to use her fingerprint log on her cell phone and has been unable to do the same at the fitness club she is a member. Which of the following drugs has she been treated with that explains this? And these are not fun to pronounce. Abemaciclib, capecitabine, doxorubicin, eribulin, and E, which is actually carboplatinum. So which one of these do you think she got? So what she actually got was B, capecitabine, and this has been described quite a few times. So this is not something that's just sort of one of those case reports that's goofy. This is a study of 20 cases reported in literature. One prospective study showed loss of fingerprints in 14%, 9 of 66 patients treated with it. All of these had hand-foot syndrome, which is well described with this. So the fingerprint thing is something people have to look for, but hand-foot syndrome is well known with this. But interestingly, the loss of fingerprints is not associated with how severe their hand-foot syndrome was. So I think this is kind of a real interesting one, whether they'd ask you about the fingerprints, but they may well ask you about hand-foot syndrome because it's not an uncommon common side effect of this treatment. A 64-year-old gentleman with a 60-pack year history ongoing tobacco use presents the clinic with progressive weakness. He's alert and oriented times 4, temperature is 37, blood pressure 125/62, heart rate 94, respiratory rate 18, O2 sat is 92% on air. He has got bilateral ptosis, lungs are clear, no lymphadenopathy, proximal weakness in bilateral upper and lower extremities with absent reflexes. Reflexes improve after isometric exercise. Chest x-ray shows a centrally located 4 centimeter lung nodule. What is most likely cause of his weakness? Lambert-Eaton syndrome, hypercalcemia, hyponatremia, cerebral metastases, or spinal cord metastases? Okay, you did great. All of you got Lambert-Eaton syndrome, which is certainly correct. A 59-year-old man presents with dizziness and nausea, ataxia, and 3 falls in the last 2 days. He has also had diplopia. Past medical history, 75-pack year smoking history, hypertension, and depression. Current medications, irbesartan and escitalopram. His sodium is 127, BUN is 3, creatinine is 0.8, chest x-ray, a 7 centimeter hilar mass, brain MRI, no metastatic disease or stroke. Which of the following is most likely to be found on further testing? Antibodies to MA proteins, anti-TR antibodies, anti-WHO antibodies, anti-YO antibodies. Okay, so the right answer here is C, anti-WHO antibodies. So this is a patient with very likely lung cancer. And if I had to guess, I'd potentially guess that he has small cell because he's got pretty significant hyponatremia. We get confirmation with the very low BUN and the normal creatinine here, these low BUNs are seen in people with SIADH. So I think he probably, if I had to guess which kind of cancer he has, that's what I think he has. Um, we go through these different markers, and anti-WHO is associated with small cell lung cancer, anti-YO associated with breast and ovarian cancer, anti-TR with Hodgkin's disease, and antibodies to MA proteins associated with germ cell tumors. They've done a lot more in the last decade with getting these antibody panels. So I think these ones that are so clearly associated with certain malignancies are probably worth knowing. I could see a question being written by a diabolical person to test on that. When we look at neurologic paraneoplastic syndromes with small cell lung cancer, we got the Lambert-Eaton syndrome, which was our first case where there's proximal muscle weakness, absent reflexes that get better after isometric exercises. And then cortical cerebellar degeneration is the second case that I gave you. These patients present with ataxia, dizziness, and nausea. And what's interesting is they tend to have a sudden onset of this. And they often have nausea, dizziness first, vomiting happening over 24 hours, then the ataxia, and then some of the more clear-cut neurologic abnormalities like diplopia or dysarthria. So the sudden onset is kind of a little bit of a surprise if you think it's something that's more of a degeneration. And the anti-WHO antibodies are present in about half of these people who have small cell who develop this. An 84-year-old gentleman with 65 pack years history of tobacco use and no metastatic lung cancer on no specific cancer-related therapy due to poor performance status presents the emergency department with confusion and abdominal pain. He is visiting Seattle from out of town. He's working on his bucket list and comes with no records. Serum calcium is elevated at 12 milligrams per deciliter. What is the most likely cancer type? He can't tell you. He just says he has lung cancer. What do you think he has? Small cell lung cancer, adenocarcinoma of the lung, squamous cell lung cancer, or carcinoid of the lung? So the right answer here is squamous cell cancer. And it, it doesn't have a lot of paraneoplastic syndromes, but it does release something that sort of tracks like PTH like hormone. So it can raise calcium levels. And small cell lung cancer, which does everything else, generally doesn't cause hypercalcemia unless they have widely metastatic disease to the bone. So this is one where I think people often think, oh yeah, I know that small cell does all those things. Well, this is one where squamous cell, and it's all squamous cells. It's not just squamous cell of the lung that has the risk for causing hypercalcemia. So when we look at hypercalcemia with squamous cell lung cancer, it's usually due to this parathyroid like hormone. It can be due to metastatic disease, but this one is usually more hormonal. Um, some of the other paraneoplastic syndromes we will see in individuals with lung cancer is hypertrophic osteoarthropathy, which will cause very pronounced clubbing and cause a lot of pain as well. So these patients may present with hand pain. You see the clubbing and can figure out with that. Regular digital clubbing, which without the pain, is we see flattening of the angle between the nail base and the cuticle. The best way to tell about digital clubbing is just have the person put their finger in profile, and your joint here is supposed to be bigger than the nail to the fat pad. And if the nail to the fat pad's bigger than the joint, then you have clubbing. Some of the different paraneoplastic syndromes with small cell lung cancer, Cushing syndrome in 2 to 5%, and then SIADH causing pretty profound hyponatremia in about 16%. A 70-year-old gentleman with 55 pack year smoking history and 6 months of cough and weight loss presents with 1 week of hemoptysis. Chest x-ray shows a right upper lobe mass. CT chest and abdomen confirmed 6 centimeter right upper lobe pulmonary mass with mild mediastinal lymph node enlargement. CT guided biopsy of the lung mass reveals adenocarcinoma of the lung. PET CT shows large uptake in the right upper lobe lung mass and low level uptake in the mediastinal lymph nodes. MRI of the brain and mediastinoscopy with lymph node sampling shows no cancer. Performance status is good. So, what is the most appropriate treatment option? Surgery with subsequent chemotherapy, or immunotherapy? So the right answer here, this patient with good performance status and resectable tumor should get surgery with subsequent chemotherapy. And we're going to go through some of the recommendations on that. It's a little bit surprising. You go, well, gee, he's got all these nodes there. Isn't that a problem? Well, he would be considered a stage 2. Tumor is between, it's over 5 centimeters, but it's less than or equal to 7 centimeters. And he's got regional lymph nodes. So he fits that very, very, very well. So he's going to fit into stage 2. For stage 2, we're going to do surgical resection for cure, then adjuvant chemotherapy plus minus radiation. Stage 1 individuals generally get surgical resection and don't always get adjuvant chemotherapy, especially if it's a very small primary. They may just get surgical resection. Stage 3, patients get surgery, then chemotherapy and radiation, or depending on their performance status or how big the tumor is and where the tumor is, they may only get chemotherapy and radiation. Now, a couple of things. Our patients with poor performance status, we probably are not going to be giving them chemotherapy because chemotherapy will probably be fatal for them. The other thing is we have to make decisions on whether patients are candidates for resection based on their underlying lung function and other medical illnesses they have. So this is a suggestion, but the important thing is always reassessing performance status. A 75-year-old man presents to the ED with a 3-week history of facial swelling and headache and a 2-week history of dyspnea. He had a 100-pack-year history of cigarette smoking. Blood pressure is 110/70, pulse is 105, temperature 36, O2 sat 92%. Diffuse facial erythema present and neck veins are dilated bilaterally. He has a 9 centimeter medial right lung mass and large mediastinal lymphadenopathy. Severe SVC compression is present. What is the most appropriate management for this patient? Biopsy of the lung mass, immediate radiation therapy, placement of an SVC stent, begin carboplatin, or begin pembrolizumab. Okay, so the right answer here, I believe, is A. We need a biopsy of this, and we don't need to jump right in with urgent radiation before we do the biopsy. This is something that's changed. When I was in residency, SVC syndrome was considered an oncologic emergency. It was considered you do treatment before anything else. And subsequently, in recent years, that has changed. And so the idea is if the person if the person has major pulmonary compromise, really has severe cerebral edema, then you may put a stent in. But the stent is going to be probably problematic. So it's kind of a last ditch thing we do if we need to buy ourselves time. Usually you can do a biopsy and then you can do some targeted treatment. You can decide what kind of tumor it is, whether they need chemo, whether they need immunologic therapy, whether they need radiation in addition to both of those. You can come up with those because there's a mix of what these are. Small cell cancer in a quarter, non small cell lung cancer in half. 10% of these turn out to be lymphomas. So we really want to know what we're treating if we can. So this has been a change, and I could certainly see a question where they give a very stable patient who has sort of ugly looking facial swelling and some of the other things, but they don't have pulmonary compromise, they don't have severe cerebral edema. A 50-year-old woman of East Asian descent uh, presents with several months of cough. She has never smoked and she has no known pulmonary disease, no nausea. Chest x-ray shows a left peripheral lung mass. CT chest and abdomen shows 4 centimeter left lung mass, hilar and mediastinal lymph node enlargement and pleural effusion. A CT biopsy of the mass shows adenocarcinoma. Which of the following is the most appropriate management? So she's 50-year-old non-smoker, no pulmonary disease, but she has 4 centimeter lung mass, hilar and mediastinal adenopathy, and a pleural effusion. Which of the following is the most appropriate management? PET scan, surgical resection, EGFR mutation testing, carboplatin plus docetaxel, or hospice referral? So which of these is the right management? So the right answer here is C, EGFR mutation testing. So this, I think, is very testable because this has really changed our approach to lung cancers in some patients that we find very susceptible lung cancers, and even metastatic disease patients can do remarkably with complete remission. So we we want to know who those patients are so we can get appropriate therapy for them. So when we look at lung tumors in non-smokers, differential diagnosis, non-small cell lung cancer, carcinoid, and always remember, it could be a metastatic malignancy from a non-lung source. We are seeing more and more non-small cell lung cancers popping up over the last 20, 25 years. Adenocarcinoma of the lung with epidermal growth factor receptor mutation is most common in women of East Asian descent. Much better prognosis than those who don't have it. And these patients get EGFR tyrosine kinase inhibitors, and there are a bunch on the market and some absolutely remarkable responses. I don't know if you folks have seen some of that. I have two patients now who had metastatic disease, one who is now about 10 years out, another one who's 6 years out with no evidence of disease. And, years ago, they would have been a hospice referral. So big difference. And I think that's one of those big onc changes. So we got to know about that, doing that testing and knowing what to do if they have that positive testing. 60-year-old woman with a history of metastatic melanoma presents to the ED with a 5-day history of diarrhea. She has eight to nine loose stools daily, some abdominal cramping. She has had no recent antibiotic use, travel, or history of bowel disease. She has just received the fourth of 4 doses of ipilimumab therapy. Her temperature is 37, blood pressure 120/80, pulse is 100, abdomen is soft, non-tender, increased bowel tones, hemoglobin 13, hematocrit 39, white count 9,500 with 65% polys, AST 170, ALT 140, BUN 29, creatinine 1.3. Which of the following is the most appropriate next step in management? Oral vancomycin, GCSF, high dose IV steroids, or supportive care? So the right answer here is giving her high dose IV steroids. Fortunately, she just got her last of this, but this is probably triggered by her checkpoint inhibitor. And what we need to do in these patients, depending on how sick they are, and she's fairly sick. She's got involvement in her liver. She's got a colitis from it. Many of these people have rash, they have hepatitis, they have enterocolitis. Sometimes they can get acute thyroid disease. and ipilimumab is the most likely, but it can be triggered by all of these. In these patients, you should stop the drug. She's already gotten her last infusion and get them on steroids. So just to recap some chemotherapy side effects you need to know, here are the ones I'm guessing are the most likely you're going to get asked about. Peripheral neuropathy, platinum compounds, zinc alkaloids like vincristine, vinblastine, and taxanes all can cause peripheral neuropathy, and the peripheral neuropathy can be permanent. Cardiomyopathy, another favorite question is asking which of the drugs cause cardiomyopathy: anthracycline, cyclophosphamide, and trastuzumab. So those are the ones that are better known for cardiomyopathy. 84-year-old man with known metastatic prostate cancer presents with several month history of back pain and 1 week of lower extremity weakness with no trauma. On physical exam, point tenderness over T12 vertebral body, decreased bilateral lower extremity strength, increased bilateral lower extremity reflexes, and bilateral extensor plantar reflexes. MRI of the thoracic and lumbar spine shows radiographic lesion typical of metastatic prostate cancer, T12, with associated spinal cord compression. What is the most appropriate initial treatment? Radiation therapy, corticosteroids plus radiation, bisphosphonate, chemotherapy, or corticosteroids? Yeah, so steroids and radiation. So the radiation can cause a little more inflammation. We want to put them on steroids. The other thing is that he's had a relatively rapid neurologic loss. So there's probably edema around some of the necrosis around the tumor. So trying to get some diminish edema with the steroids will get that benefit, and also will be somewhat protective when we radiate and try to radiate the tumor. So for spinal cord compression, most common tumors to do this are breast, lung, and prostate cancer. Weakness, pain, hyperreflexia, extensor plantar reflexes. MRI of the entire spine is the best way to diagnose this. And when we get new neurologic problems, we don't want to do just focal MRI. We want to get a complete MRI because people can have METs in multiple different areas. Get steroids there, surgery if needed for urgent decompression, radiation therapy. And then if we know that somebody has a sensitive tumor, we can do chemotherapy. We wouldn't want to do chemotherapy alone, probably not do radiation alone. We want to combine these. A couple of comments on Cauda-Equina syndrome. It gets talked about a lot. Saddle anesthesia, so patients have a change in sensation in the area where their butt would hit a saddle. Lower extremity weakness, they can sometimes just get mostly radicular pain before they get the weakness, and then bowel and bladder dysfunction. 67-year-old man undergoes colonoscopy for bright red blood per rectum and is found to have a 3-centimeter adenocarcinoma located 8 centimeters from the anal verge. Contrast-enhanced CT of the chest, abdomen, and pelvis shows no evidence of METs. Endorectal ultrasound reveals full thickness involvement of the rectum with no lymph node involvement. So he's a T3N0M0. So this is a person who's been found to have an adenocarcinoma 8 centimeters from the anal verge, and it's full thickness involvement without any evidence of metastatic disease. What is the most appropriate treatment? Surgery with subsequent chemotherapy and radiation therapy, chemotherapy and radiation, then surgery, then subsequent chemotherapy, or chemotherapy and radiation therapy. So I think this is a hard one, and these types of things do change. I think probably C is the best thing to do to try to get this a little bit smaller before the surgery, and then they would get adjunctive chemotherapy after that. Um, so radiation and chemo before surgery and chemotherapy after surgery, because this person is stage 2. He's T3N0. 42-year-old HIV positive gentleman presents with rectal pain and bleeding. Physical exam reveals a 2 centimeter mass in the anal canal. Colonoscopy shows no other masses. Biopsy of the anal mass reveals invasive squamous cell carcinoma. Contrast enhanced CT of the chest, abdomen, pelvis shows no evidence of METs. Endorectal ultrasound confirms a 2.3 centimeter mass in the anal canal with no perirectal lymph node involvement. What is most appropriate treatment? Surgery is subsequent chemotherapy and radiation therapy, or radiation therapy and chemotherapy. So the right answer here is radiation and chemotherapy, and that sometimes comes as a surprise. So for for anal cancers, they can be cured with radiation and chemotherapy. Certainly the earlier stage cancers, and we don't see any lymph node involvement here, and the person doesn't have metastatic disease. This tumor can probably get destroyed with radiation and chemotherapy. And the question you may have is like, well, why not just remove it? And some of the reason for that is that the surgery can sometimes have a real negative impact on the anal sphincter, and so continence can be a problem. So these sparing treatments with radiation and chemo are often done in patients who have earlier disease. So treatment is usually combined radiation and chemotherapy with curative intent, and you only do surgery if the radiation and chemotherapy fails. Now, this was a patient with HIV disease. Many of those patients have HPV, and these cancers are almost all HPV driven. They're very, very common. And there are recommendations for screening for anal cancer. These haven't gotten all the way to like the U.S. Preventive Task Force type of recommendation, but certainly in your patients that are higher risk, the ones with the lower CD4 counts, absolutely appropriate to be doing regular screening. Ideal screening is actually with high resolution anoscopy, but we don't have enough people trained in that. So we sometimes just resort to anal pap smears. 34-year-old man presents with sore throat that has been present for 3 months. He was treated with 2 courses of antibiotics without improvement. On exam, he has erythematous lesion adjacent to his right tonsil. He has a 4 centimeter anterior right cervical lymph node as well. Biopsy shows squamous cell cancer. What is the most likely risk factor in this patient? Is it tobacco use, marijuana use, alcohol use, or HPV? So the right answer here, I think most of you picked HPV, and especially when you see younger people with throat cancers, especially tonsillar cancers right around the tonsil or involving the tonsil are very HPV driven. And then again, younger people, we've seen a real rise in this in the last 20 to 30 years. So when you see squamous cell cancers in older patients, it's most likely due to tobacco, alcohol, combination of those. Again, the tonsillar cancers, younger patients favor HPV. The outcomes are much better in younger patients, and these patients do very well with radiation and chemotherapy. Many of them don't need surgery. Some of them get surgery as well, but they don't. It's very, very different outcome than the cancers that we have seen with alcohol and tobacco sort of as a trigger compared to HPV being the trigger. think this is our last case. A 67-year-old man presents with decreased energy, dull right upper quadrant pain, and weight loss over 6 months. Vitals are normal. Temporal wasting, hepatomegaly, fluid wave, and lower extremity edema are present. Rest of exam is normal. His basic chemistries are normal. CBC shows mild anemia. Albumin is low. Alkaline phosphatase and bilirubin are elevated. PSA is normal. CT of the chest, abdomen, and pelvis demonstrates ascites and multiple hypodense lesions replacing over 50% of the liver. Needle biopsy of liver lesions shows moderately differentiated adenocarcinoma. Upper endoscopy and colonoscopy are normal. Empiric chemotherapy for which of the following primaries is appropriate? Lung, prostate, testicular, gastrointestinal. Okay, so everybody got this one right. Everybody's picking GI cancers and this person who has a lot of stuff below the diaphragm. So this person has carcinoma of unknown primary, and these are getting rarer and rarer because we're so much better at being able to run all sorts of panels on every biopsy. Some of the more undifferentiated tumors, we don't find that, so we still do carcinoma. We do still do see cancer of the unknown primary. Um, the immunohistochemical markers, as I said, are better, but they're not perfect. So generally, when we see women with this in the axilla, we assume it's breast cancer. With women with ascites and abdominal carcinomatosis, ovarian cancer, young men with tumor in the mediastinum, retroperineum, testicular cancer, adenocarcinoma below the diaphragm, like this case, GI cancer, adenocarcinoma above the diaphragm, we assume it's lung cancer. So that's the best we can do with these when the immunohistochemical markers are not present, and then we can target treatments with a guess on what type of cancer it is by location. So just the last sort of wrap up, key solid tumor information for the boards. Know your paraneoplastic syndromes, hypercalcemia, squamous cell over small cell, no side effects with chemotherapy, immune therapy drugs, rash, diarrhea, checkpoint inhibitors, causes of neuropathy and cardiomyopathy, and know how different forms of lung cancer are treated. I think that, if I were writing questions, lung cancer has really changed so much in the last several years. And so I think those are fair areas for questions. If you have any questions, happy to put them in the chat or happy to handle them or not handle them.
You might
They're
punt.
oncology questions.
I don't see any in the
That's why
chat.
we have Rachel here to answer all the oncology questions.
Oh, no pressure there. I at least know how to phone a friend oncologist, but I don't see any yet. A lot of thanks for joining, for running this marathon. You were the pacer for us, which I always appreciate, Doug.
Okay, well, it was good and good luck to all of you.
Thank you. They are well prepared with all of your content. All right, folks, that is it for today. We'll give you a little bit of your evening back. As a reminder, we start bright and early sharp at 8 o'clock tomorrow morning. The Zoom will start at 7:45, so be sure to log on time, and then we will get started. See everyone in the morning. Thanks.
Okay, well, let's see. We'll get you out a little bit early.